Hello dear students, welcome to Simplifying OBG session. In today's session, we'll be discussing about how to manage an ectopic pregnancy. You all know that this Simplifying OBG session is dedicated to very small lectures, small topics where we study the topics in very interesting manner. So, in ectopic pregnancy, when patients present to you, there is a classical triad with which patient presents. What is the triad with which patient will present? The triad has a mnemonic VAP, V-A-P. इसका mnemonic है VAP. Number 1 is vaginal bleeding. So, patient will come with vaginal bleeding or spotting. This is very important. Number 2, there will be history of amenorrhea. Because patient is pregnant, so patient will have amenorrhea and urine pregnancy test will be positive. It may be faint positive also depending upon beta HCG का value कितना है. And P is for pain abdomen. So patient will have pain abdomen. So this is the classical triad with which patients of ectopic pregnancy present. The most common site of ectopic pregnancy is fallopian tube. And in the fallopian tube also the most common site of ectopic pregnancy is the ampulla of the fallopian tube. So always remember, the ampulla is the most common site of ectopic pregnancy, followed by rest of the parts of the tube. Then you can have cervical ectopic, you can have ovarian ectopic, you have abdominal pregnancy and rest other types of pregnancy. So when patient comes to you, how will you manage? Always remember, management when it is asked in examination, you have to start with diagnosis, followed by treatment of the patient, and then lastly you have to go for follow-up of the patient. Okay, so for diagnosis you have to have history, examination and then investigation. So basically you are writing everything when it is asked regarding your management. So history, patient will have the classical VAP syndrome, VAP symptoms, so this you will explain. Then on examination, what will you do? Examination, what you will find is on per abdomen examination, patient will have rigidity. Per abdomen, there will be, the muscles will be rigid, the abdominal muscles will be rigid. There will be guarding present because patient is having a lot of tenderness. Abdominal tenderness is found in the examination of a patient of ectopic pregnancy. At the same time, you should always remember there is one sign called Cullen's sign, very important. What is Cullen's sign? Cullen's sign is bluish discoloration around the umbilicus. So patient might have bluish discoloration around the umbilicus, which is found in patients of ectopic pregnancy. This bluish discoloration around the umbilicus is suggestive of hemoperitoneum. When there is ruptured ectopic, patient might have this. Apart from that, patient's temperature might rise because there is inflammation in the body. Peritoneum is inflamed and irritated, because of which temperature may rise. Okay. On per vaginal examination, patient will have classical cervical motion tenderness. That is, when you move the cervix, the patient will have a lot of pain in per vaginal examination. The number 2 finding, which is most specific, is fornical tenderness. Means patients beside the uterus, means on both the sides, adnexa will be tender. The side on which there is ectopic pregnancy, there will be tenderness in the pelvis present. So these are the signs which you elicit. Apart from that, if there is rupture which has already taken place leading to hemoperitoneum, then patient will have shifting dullness. There will be shifting dullness present, which will tell that there has been rupture and there is fluid in the abdomen. Now in investigations, what investigation do you get it done? First of all, get an ultrasound done. An ultrasound will tell you whether there is ectopic mass, what is the size of the ectopic mass, and whether there is any free fluid in the pouch of Douglas. Free fluid means patients of free fluid means there is hemoperitoneum already present. There is rupture has taken place and bleeding has occurred inside the abdomen. So in the pouch of Douglas, which is the most dependent portion of the abdominal cavity, there fluid will come. Apart from that, you can get a culdocentesis done. Culdocentesis done. Now what is culdocentesis? Very important. What is culdocentesis? Culdocentesis means, you know, that the most dependent portion, if I take a sagittal suture, sagittal view, this is your bladder, this is the uterus, and then you have the rectum coming. Okay, so the peritoneum gets reflected in such a manner that in the posterior part it is the most deep. So this is the pouch of Douglas, which is the most deepest portion of the abdominal cavity. So when there is hemoperitoneum, the fluid will be collected in this pouch of Douglas. So blood will be collected in this part. Okay, so what happens, what you can do is, in the posterior vaginal wall, okay, you can insert a needle and then go to the pouch of Douglas and you can aspirate the fluid. Okay, so this is the needle and then it will show blood. So similarly, what you will do is retract the posterior vaginal wall with a sim speculum and the anterior vaginal wall with anterior vaginal wall retractor. After that, catch hold of the posterior lip of the cervix with the valsillum. Okay, so always we catch hold of the anterior lip of the cervix. This is the only indication where you catch hold of the cervical posterior lip with the valsillum. After that, in the posterior vagina, you make a hole, insert a needle and it goes to the pouch of Douglas and it brings out the fluid. If there is blood present in culdocentesis, it means it is a ruptured ectopic. Ectopic pregnancy. Okay, so now how do you manage? Also at the same time, you also get a beta HCG done. Beta HCG is done because beta HCG will help us to govern what type of management we will do. Okay, now based upon beta HCG, what can we do? Okay, beta HCG can be low, can be high. It can be low, it can be high. So we have three types of management for ectopic. One is expectant management. In expectant management, what we do is, we will not do anything, we will just monitor the beta HCG of the patient. So what we will do is, we will ask the patient to get beta HCG done after every 48 hours. That is, after every 2 days, she will get her beta HCG done. If the beta HCG is in falling trend, if the beta HCG is falling, then nothing has to be done. But if the beta HCG is slowly in rising trend, then you have to go for either medical management or surgical management. Expected management is done when beta HCG is less than 1000 international units. Okay, when it is less than 1000, then you can just monitor whether it is falling or not. The second management which we can do is medical management. Medical management is done with various drugs. The most important is methotrexate. Then you can do with mifepristone. Mifepristone can also be used in certain cases. Then you have other drugs also like potassium chloride and etc. you have. Okay. Now the most important is methotrexate. With methotrexate, what we do is, we inject 50 milligram per meter square of methotrexate is injected deep intramuscular methotrexate is injected. One vial of methotrexate contains 50 milligrams, okay, in 5 ml vial. Okay, so body surface area of normal individuals is 1.73 meter square. So you need around 80, near about 75 to 80 milligrams of methotrexate is required. So how do you give? At day 1, first day, you inject methotrexate. Injection methotrexate is given on day 1 and you ask the patient to repeat beta HCG on day 4 and day 7. On day 4 and day 7, patient gets beta HCG done from the same lab. Okay. So if the beta HCG value between day 4 and day 7 falls by 15%. 15%, that is, if there is fall of 15% at day 7 from day 4, then you say treatment is successful. But if the fall is less than 15%, then you have to either repeat methotrexate or you have to go for surgical management. Now, who are the candidates for medical management? The prerequisites for medical management are that beta HCG should be less than 5000 international units. If it is more than 5000, you have to go for surgical management. Then size of the ectopic mass in ultrasound should be less than 4 centimeters. Size diameter should be less than 4 centimeters. Number 3, patient should be hemodynamically stable. If patient is not hemodynamically stable, patient is having shock, it means it has already ruptured, then patient should go for surgical management. Next, it should be an unruptured ectopic pregnancy. Unruptured ectopic can go for medical management only. Then patient should be compliant. It means that patient should follow all your advice and come to you immediately if there is pain, abdomen or bleeding. And number 6, patient should be living nearby. To the hospital. Because if there is any time patient is having severe bleeding or severe pain abdomen, she should come immediately to the hospital. Next, coming to the third management, which is the surgical management. So what do we do in surgical management? Surgical management can be broadly divided into 2 types. The classical one is salpingectomy, means we are removing the tube in which there is ectopic. So जिसमें ectopic प्रेगनेंसी हुआ है और जो फट गया है उस ट्यूब को आप काट के रिमूव कर दो. बट देन देयर विल बी अ रिस्क, लाइक सपोज पीपल somebody had ectopic on one side, on the left side, and the tube is removed. Next time she has again ectopic on the right side, so you cannot remove both the tubes and patient has no baby, so she will need one more baby, so you may not be able to remove the tube. So sometimes you have to go for conservative management also, conservative surgery. So conservative surgery for ectopic can be of 2 types. Either it can be salpingotomy, TOMY, or it can be salpingostomy, GOSTOMY. Okay, one has GOTOMY, one is GOSTOMY. Wherever there is os means opening, open. So what you do is, basically we take the tube, this is the tube, and we have to conserve the tube. Ectopic pregnancy was here. So what you do is, you give an incision on the antimesenteric border of the tube. You give an incision. After that, you suction out the ectopic mass. Once the ectopic mass has been removed, then this part is open. Okay, so this part is open. Now what you do is, in salpingostomy, os means open, so you leave this tube open so that it heals by secondary repair. It will heal on its own. But in salpingotomy, what you will do is, salpingotomy, there you will remove the contents and then you suture it. You suture this part of the tube. Okay, so anything can be done. Ostomy can also be done, otomy can also be done. Both have equal benefits, but chances of ectopic pregnancy again in this side is very high, because a repaired tube will not have good motility, and then after fertilization the zygote won't be transferred properly to the uterine cavity. So patient has to be explained that recurrent ectopics can be there. So this is how we treat the patients. But if patient has ruptured ectopic, then of course in rupture you have to remove the tube, and salpingectomy is the main management. So I hope you have understood. If there is any doubt, you can let me know